Well, hello everyone, and welcome to the March episode of Rising Stars. I'm Jessica Asefa, your host, here with my co-host Phil Collins. This month, we're really focused on where we're at right now in the STARS calendar. So we're heading into April, claims are starting to roll in, gap lists are getting real, outreach is kicking off, provider and vendor accountability is taking shape. And these are kind of the topics we want to lean in today, kind of a time of year where we have our foot in two star worlds, if you would, finishing up what we can for Star Year 27 while doing all we can to get a good start on Star Year 28. Phil and I are really excited today to be joined by our guest, Jay Palmer. Jay brings more than a decade of experience leading Medicare Advantage and quality and STARS strategy across HMOs, PPOs, and D-SNP products. She's held leadership roles in a number of known health plans, to name a few: United Healthcare, WellMed, WellSense. Jay, we're really glad to have you. I'll pause here and just please fill in anything I might have missed to tell the people who you are.
Well, talking about myself, favorite thing to do. Well, thank you so much, Jessica, and thank you, Phil, as well, for this opportunity. Yeah, I think you kind of summed it up. I will just add, aside from my technical skills, I have along my career have also positioned myself as a builder as well. So someone who can go into new space and create structure and governance around quality initiatives. Also an influencer. Now, this is probably one of the most toughest part of my jobs is really gaining buy-in from executive leadership as well as cross-functional teams or an engagement. And now last thing I will say about myself, not to pat myself on the back, but I am passionate about being a strategist as well. And so really making sure that I'm aligning company goals with regulatory standards, really to drive measurable outcomes. So you've summed it up and I just put a button on it. So that's
I
me.
love the influencer part. Like
I
that's such an underrated term because that's so true. You do need to influence all these teams to work together in order for stars to work.
Yes, yes. I hope we can get into that later on because, breaking the silos within the organizations is
right.
huge. Yes.
Agree. It's a topic at every single conference presentation every time for a reason, right?
Yes,
Hmm.
yes, yes, yes. And we need to keep talking about it actually. I mean, that's how we kind of break the culture and cultivate an environment where people can see, oh yeah, I do impact stars, even though I'm in claims or I'm in customer service, wherever I am, I impact quality.
Yeah, I love that. I love that. All right, well, let's jump right in. I kind of teed it up at the beginning, right? We're in the a foot in two world space from a star's perspective. So I know last month we spent a lot of time with our guests talking about the HEDIS Medical Record Review Project, how to really improve data capture and operationalize that strongly. So let's jump into the other part of HEDIS that's starting now as well, some of that prospective work where the claims are starting to flow in. You're starting to have members entering your denominators. You're start from an adherence perspective. Folks are starting to get those second fills, and today looks beautiful because everyone's 100% adherent. With all of this data flowing in, Jay, where do you recommend that star leaders start first?
That's a great point. I honestly believe that we have to get better with utilizing the data that we get early to identify patterns, right? One of the most important things that I think we can do is start identifying patterns like now. We're in March. So yes, to your point, we're starting to get claims in from January and February. There are members who have gone to see their PCP already. We could always, utilize that data to see, well, who's already seen their PCP and maybe they still left some gaps on the table. And so what we are identifying those patterns early, we'll be able to now think of interventions that will help prevent these emerging gaps and start compounding more and more open gaps throughout the year. But I think we have an obligation to get ahead of the Q3 and the Q4, um, data dive. We can start doing that today. And I think organizations that, really put a focus on early interventions, they're the ones who have the competitive edge.
That's right. Oh, I agree. and that same space, you were talking about, I loved, and Phil even double clicked on it, if that saying's not overused yet. Your passion about kind of silo busting and ensuring collaboration, tying that to what you just said about providers and some of that data coming in. Now is a time where we're really, as health plans, kicking off those value-based contracts, relationships with vendors, and providers rather, right? And those provider meetings, and sitting and talking about how we're going to work together to ensure quality of care to those populations we jointly serve. What have you found to be an effective approach at this time of year, and really kicking off those relationships well, and ensuring that we get strong buy-in from our providers throughout the year to move those measures?
Oh, I love that question because honestly, we have an obligation to um, build on. I don't think we put a lot of emphasis, or I should say, enough emphasis on building those relationships with our providers beyond just the JOCs and beyond just, hey, here's your gap list. I think, we once we're starting to gain, hopefully as a health plan, we're gaining intel on who our members are. What are some of those barriers that they're facing? What are some of those behavioral signals? And if we can start to share that intel with the providers, I do believe that now we're arming them with more information opposed to just, hey, here's your gap list, close these gaps. But here's some intel around some behavioral signals. There may be some financial constraints. There may be some like access barriers or just gaps in knowledge, right? And so we're now giving these providers more of an advantage to do their work a lot more effectively. And I will say that, when we start to treat our relationships with providers as less as transactional, and being more transformational, that's how we get and build stronger networks.
Yeah, totally. So who are the people in those gap lists, and what are the unique barriers they're facing, and how, I think this is a place, plans don't know what to do. They want to close the gaps. They send those gap lists, like you say, to the providers, and then they turn around and get in the provider's way by trying to close those gaps themselves, right? Where we need to do some of that, but sometimes we're picky about it, right? So maybe like defining that with provider groups too, right? Like, what are you going to do to close those gaps? And did you know, like to your point, Jay, these are the member demographics that are in this gap
Yes.
list that I'm giving you.
Yes.
Here's the unique subsets, and here's the benefits. I mean, we're at bid season, right? Here are the benefits that we've put in place to help. I mean, that's where the health plan strength really is, right? To help close those gaps.
Yeah, I think too, health plans have to not get too excited about HEI going away, right? Because at its core, kind of like what Jay was referring to, we still have an obligation to care for those members, right? And yes, while we may not be getting, those extra points anymore, they're still typically, the lowest compliant members, and there's a reason for that. There is whether it's transportation or financial or whatnot. So I think that's we were quick to see people not want to send us SRF data anymore, with HEI going away, but it's still a crucial part in improving your care management measures for sure.
100%. I love that, right? And don't be Target, right? And just be quick to close your DEI program, right? There's a lot of work to be done with it. That didn't play out well for them, right? It won't play out well in Star's strategy either. There's a
Nope.
lot of work to be done to move, to and improve the health of these different populations and different member demographics, within our health plan, within our contracts. And there's no
Yeah.
winning stars, HEI or none. You're right, Phil. Like there's no winning stars without doing that hard work.
Yep.
If I can share, there is, and I love that this came up because I have one thing that I can say that, throughout my career, we've become so um, mainly concerned about the numerator, right? Which is important. We
Yes.
want to know who's closed their gaps. But I do believe that if we can get into a place where we're also putting some emphasis on the denominator, so And I say I coined this term, and I hope I'm not taking anyone else's IP, because I've never heard it before, but I call it denominator intelligence. And maybe it's not me, but whatever.
I like
But
it.
I love the idea of, like I mentioned before, like who understanding who's in the denominator and of that why, and taking it a step further and making sure that we are intervening in a way that speaks to those members. A lot of times it is embedded within our culture that we're deploying the same strategies, the same
Hmm.
interventions year over year because it's on autopilot, or because it's convenient, or this is what the resources we have within our organization. But I would love to just encourage your listening audience to really think about member segmentation. I think that is so important. And that really looks like, identifying who these members are, interrogating through, analytics and seeing, okay, again, let's uncover these root causes and let's look at some historical data as well. But segmenting, I think, is so important because now we can say, these are the members who have a high likely of closing their gaps. Maybe um, they have seen their PCP within the last year. Maybe they have claims within the last 90 days. Maybe they've closed a couple of gaps, but just not all the gaps. So their intervention might just be a nudge, right? Versus the members who would fall in a low probability to close a gap. They haven't seen their PCP in a year. Maybe they have sporadic claims. They might need something different. They might need a community-based intervention. I don't know. But my point is, if we can segment these members, we are now deploying and intervening in a way that's tailored to these members. Now, I know we cannot solve for every single scenario that's out there,
Right.
transportation, and we can't solve for everything. But if we could at least identify like what those bigger trends are, we can build a lot better in that way. And I will say I do believe that organizations that are data literate, they are the ones that close gaps more efficiently.
Yeah.
Yeah, denominator what? What did you call that?
Denominator intelligence.
I know.
Denominator.
I actually
I
just
love that.
trademarked that right now, Jay. So
Right? You
we'll work out a
trademarked it.
royalty thing here.
Man, I missed it.
It's
I
so
missed
good.
it. I actually just, and I'm going to post it. I actually just wrote an article about it recently. I'm going to actually post it. Now you got me excited about it because I've been using the term, and I'm like, you know what? And I don't know if
Hmm.
I'm taking someone else's IP, but I love the idea of segmenting, your membership.
I do too. Look for the
Yeah.
article, people. So there we go. Tweetable moment brought to you by Jade Palmer. Denominator intelligence. Don't just look at who's in your denominator. Understand why.
Why? Yep.
Understand why,
I've
and
not done,
understand
I
what.
I
love
think
that.
done that to some extent, but not so intentionally. The way you just said
Mm,
it, right? Like, hey,
mm-hmm.
here's our denominator team. Let's do some deep digging to find out why every single member is in this denominator.
Yes,
We
yes,
jump
and
ahead to the next step.
yeah, right. I mean, honestly, this when we start to, I think organizations that hold their stars um and versus those that lose ground, they really it all comes down to execution discipline. I mean, again, it's easy to just say, oh, and I just wrote a post the other day, not to be these shameless plugs, but I did do a post recently on fit kit churn. It's a real thing. We
Right.
are just like churning
Hmm.
these same strategies, and while you may get like a 15% lift because of this fit kit campaign, these members are going to be chaseable again next year because it's a
Yes.
1 year measure. We
Yeah.
need to get beyond just like these like mundane. I'm gonna call them mundane strategies that we just do year over year.
And they're really fire drills, to be honest. Like from a
Yes.
numerator perspective, they're fire drills. A
Yeah,
denominator approach is being proactive about it. Like,
yeah.
I totally understand that and love that.
I
I do
like
too.
that fire drill. I like that. That's a good. That's a good point.
It is. I mean, Jessica and I know how many times,
Right.
Q3, Q4 hits and you're like, we need to get some kits out, or, the
Hail
A1C
Mary. I know.
strips, all that. Yeah, anything. And you actually said something, Jay, that I'll go back to. You said the health plans that hold their stars. I feel like that's what they do. They understand their denominator. They're
Mm.
proactive.
Mm-hmm.
So much. I feel like so many health plans achieve a certain star rating because they succeeded at a fire drill that year and they can't replicate it the following year. And
Yeah.
that's where, you end up with these drops in star ratings. People are wondering what happened. Well, we did kits in Q2 instead of Q4 where people didn't
Mm-hmm.
want to go do them. And I definitely think, you know, proactive versus running around, like we've got our stars heads cut off kind of
Yeah.
is two different strategies for sure.
A- Absolutely. We definitely have a lot of work to do, especially now that, the industry and everything is changing. I think, and I do believe that things are going to become more stringent, mandates and policies, and you know, so I do believe that we have a lot of work to do to get it right, and we can't keep using these antiquated ways of approaching quality. That's just my
Yeah.
opinion.
Really,
I don't
no,
mean to.
you're right on. There's no easy button, right? Fake hits is,
Well,
is the
people think
ultimate.
there's an easy button, and that's the problem. Don't use AI to develop any sort of your quality
Oh,
initiatives, people.
that's right. That's right.
I that is my biggest fear is that we're going to see people, fall into these positions because they're using AI to sound good, develop these programs, and you're still not connecting with the members. And
With the
that is at the end of the
members,
day was what matters.
and that is actually kind of scary, you know. I'm being
It
honest.
is.
Yeah, we're losing sight of the true reason that we're here. And I don't want to derail the conversation, but there's like another, I don't want to call it pet peeve, but it's something that I'm like passionate about as well is, you know, making sure that we're not so much in the rat race of chasing stars,
Hmm.
and we're treating members as if they're just a member ID, and not, you know, human. I think that's another piece. And it's easy to get caught up in a rat race. It truly, truly is, especially as we get through the gear and we're hustling and bustling. So, but yeah, that's just another
Yeah.
side note.
It is. It is. What about vendors? Let's talk about vendors. We talked about like member outreach. We talked about partnering with our providers and trying to do that in a collaborative way, in a meaningful way where we're coordinating and not stepping on each other's toes. Now is a time of year where we also have health plans kicking off all those vendor relationships. Those vendors we all signed up with Q4, and they've got a
Hmm.
1/1/26 start date, right? And now they're getting the data coming in. Let's talk about that a little bit. How do we make sure that we have effective vendor management, vendor oversight, and coordination between what our vendors are doing, what our doctors are doing, what our plan is doing?
I love that question. If you would allow me to just kind of give an experience that I've had.
I
uh,
will allow it.
well, thank you. So when I
Wait, was it
joined,
with us? Because if it was with us, you can't share it.
no, it was not. I will say, when I joined an organization, I mean, it was when I joined another role within the organization. One of the things I noticed in all the meetings I was going to, this now I'm in just a discovery mode because I'm new to the role. And one of the things I discovered was that just about every meeting we were having, like strategy meetings, this particular vendor kept coming up, right? And so people really held a lot of faith into this particular vendor. And I thought this is great. They've had the vendor year over year, and I think what happened is along the way they put their trust in the vendor. Maybe they had some focus on the vendor's activity the first couple of years or first year, but once they felt like they did well. They kind of the oversight was diminishing. So because I was in discovery mode and learning about different data points and things of that nature, I realized that this particular vendor was not performing as I kept hearing in emails and meetings. And so I raised a red flag, and eventually um, I was told, okay, well, this is what you're going to focus on right now. So now that's like my first project is really this vendor oversight. And really what I determined is that they had some organizational shifts and things kind of fell through the cracks. And so, unbeknownst to us, we're just thinking we're reporting out what they've done in the past, opposed to really having a clear understanding of what's going on today. And so, long story short, because of that, I did have to build like some governance around this project, making sure that now I'm changing the trajectory. I'm changing up how we have done things. I'm like, okay, now every single week we're going to get some sort of fulfillment file. If anything comes up, any roadblocks, let us address it. Bring it to our attention. Let's address it immediately. And within like I want to say 6 months or so, we started to see an uptick in performance, just really based off of that oversight, that extra oversight. And again, it was just interesting because I don't know. I'm just assuming it seems like people were focusing on the previous year's performance and how well we've done, and they just I don't know, but it was not
run the
performing.
business. Yeah.
Yeah.
Stop
Yeah.
thinking
Yeah.
of it as a
Yeah. So I
strategy
hope that
and
answers your question. I mean, yeah, I think you have to have your eyes on the prize. You have to understand what it is that they're
Right.
doing, identifying it, and of course, they had some org restructuring as well. And again, that's kind of really the real reason why things fell through the cracks, is because they didn't really have dedicated entities on our work.
Mhm.
So, yeah.
I love that. I mean, I think what's equally important, right, is you understanding what the vendor does and can do and will do. Equally important is for that vendor. I actually like vendors that use the word partner. Like if you're their partner, not a
Yeah.
vendor, I love that, rather than, oh, we're a vendor, the vendor or partner has to want to understand your health plan and your population. If those questions aren't asked in a sales pitch, like they're just going to be throwing spaghetti at the wall to see what
That's
fix,
right.
what sticks. Are they, adaptable? Can they change, based on your guys' population, or are they cookie cutter vendor that, you know, thinks the solution for health plan A in Massachusetts is going to work for health plan B in Florida?
Right. Yeah, totally. I really like Jay, how you were talking about bringing structure and governance to that vendor partner relationship as well, and it just made me think about just the import, like what is strategy without structure and governance, like how do we implement it, oversee it, monitor it, refine it, tweak it, how do we escalate barriers and bring down direction, and what in your experience has been, I mean, I know it's a heavy question, but in your experience in managing stars, what are some of the key components you've seen as an effective structure and governance over over a strong star ratings program, and the role a star leader plays in that structure?
Yeah, that kind of goes back to what I mentioned earlier around like those, breaking those silos. I think, you know, it is really easy to find yourself in an organization that everyone has we used to call them blue chips. Everyone has their priorities, everyone has their own goals, and no one's making the connection. And I think, once if there is that one person who could be the one to say, hey, I'll give you another example. I'm all about examples. But another time in a new role, uh, because I was in a new role, I had the opportunity to do all these meet and greets, right? And it was very, very clear and evident right away that a lot of the work that was being done by various teams was duplicative work. They were just working in silos, and the right hand did not know what the left hand was doing, but they were touching the same members, and that was a problem. And so I raised my hand, I raised the red flag, and at the time, my leader at the time was like, "Well, bring them together." And so I created like this like I forgot I think like a joint commission. I forget what I call it, something fancy. I don't remember, but I made it a 2-hour meeting. I wanted all of these individuals these leaders that I've met with, to come together and share. I asked them to come together and bring to the table what you're focusing on, what your goals are, what your resources are, that kind of thing. I wanted them to hear just how much they're all duplicating their work. That was the point of that initial meeting. And there were so many questions. The call needed to be rescheduled because we went past the 2 hours. Because it garnered a lot of conversation. And so then I had to do another one, and I'm like, okay, now that you all see what I see, basically, how do we come together and unify our goals, have clear expectations, build again a governance around who's on point over what. Maybe we can shift some priorities because maybe you have more resources and bandwidth than this particular team. So it took some time. And what I will say, just putting the button on this, is that within the first 2 years of now this new structure, because when I came, I had 7 H contracts that were 3.5 star. Within the first 2 years, all 7 of our H contracts reached a 4-star or better. And that is a true testament to what it looks like when you are aligned.
Right?
Yeah.
This is what happens when Jay brings denominator intelligence, right? All the vendors to the same table, letting them know that, hey, this member falls in every single one of your denominators, but they're not 3 people and they have one common problem, right?
Oh, you said it so eloquently. Yes.
There's the bow. That's right. That's right. All right. So future changes. Let's go there, shall we? Because there's so much to talk about. I know everyone's waiting on the final rule. And Jay, I don't know if you brought your crystal ball with you today, but if not, I'm going to ask you bring it up, give it a rub, and what do you see in ways of all of these changes that CMS has proposed that will just turn the program on its head? What do you see coming to fruition and maybe not?
Are we talking about, like, for instance, those 12 measures that they're thinking about doing away with? Is that what
That's right? Sunsetting HEI, which I think is kind of a done deal. The 12 measures I think that may go away. That right? What else was there, Phil? What am I forgetting? It was so chock full of.
You've got
behavior
call center
health,
and SPC for stars 28, 29. The rest of the measures would come out, and I think people still forget that hold harmless is still out there too. 4 and 5 at any point, CMS could just be like, boom, hold harmless is now only 5-star plans. So there's still a lot out there.
Right. And the request there was that blanket request too. What other measures do you think we ought to retire?
Yeah.
Let's talk about these things.
Yeah. You know what? So first of all, I will say this. Like, I was a little disheartened by the DR. I still call it DRE. I'm old school, but EED. I am still disheartened about diabetic retinal eye exam because, it's a chronic condition, number one. It's diabetes related. And I feel like, why are we ditching that? Because at the end of the day, these members need to adhere to, we need to make sure that they're getting preventive screenings around that. The call center, I didn't have any really, objections with that one. There's a couple others.
Lawsuits.
Let's be honest. That's why they took them out. They don't want to fight the lawsuits anymore.
They don't want to fight the lawsuits. And I wish I had the list in front of me because I could speak a little bit better on it. But there's a couple. I think it depends on the current standing of your organization. And the reason why I say that is because, and a part that I don't understand, I'm going to be transparent, the way how my stars math work in my brain, I almost feel like if you're ditching these 12, that's going to increase the heaviness of what's left. And so now you're going to have to churn even more, but you're going to have to really put in more emphasis on what's left. That's kind of how my brain works. But if any other SMEs, please correct me if I'm wrong. But the other piece I would say is, depending on your current standing of your health plan, if you're a health plan that's doing poorly on half of those measures, you're probably not going to, you're probably going to send comments in. You probably would have sent your comments in January that says, Yeah, I agree,
Right.
But if you are an organization who has been doing so well, working diligently on these measures,
Mhm.
and now they're talking about, ditching these measures, you're probably going to find yourself feeling like, okay, now now what? What's that shift? What is that
Right.
methodology going to look like? So I am there's a couple I didn't agree with, but then there was a couple I was like, well,
And if you
make
haven't
call
been
attention.
doing, if you're not a plan that hasn't been doing the hard work, these measures for a lot of plans are the easy button. And if Phil has
Hmm.
analyzed that to death, I know, and the impact that that's going to have, that could have nationally on plans and on plans individually. Um, but
Hmm.
without that easy button, if you haven't been doing the hard work clinically with the rest of your members, right, that the hard work that actually results in improved health outcomes and experience, these are the plans that are really going to be caught flat-footed, I think, if and when
Yes.
these operational measures come out.
Yeah,
Agreed.
those
Agreed.
operational measures, they're really measures that the health plan truly can control, right?
Hmm.
Like if you have a strong appeals review process, timeliness process, you can get 100 out of 100. If you have a strong call center, you can get 100 out of 100.
Yeah.
Um, you know, the plans that we are going to see, really struggle in 29 most likely, are the ones that those were their anchor measures. Those
Mm,
domains brought up the lower performance from, say, their pharmacy measures or the HEDIS measures. um when you remove those, and suddenly those measures that you are lower performing in become, higher, not higher in weight but higher in the calculation.
Yeah.
um it's going to be a struggle.
it's going to be a struggle. I'm definitely curious. I mean, and I guess what we will hear like early, or I should say late summer, is that kind of when
I think probably like April, May
Hmm.
is when we
I was
usually see
hearing
that
both.
trend
Okay,
open up.
okay. Well, yeah, I'm
But who
definitely I'm going to
knows,
keep
right?
my yeah
Yeah.
keep my ears to the street, because I am definitely curious to know what the outcome is going to be. I'm curious to know, I guess what the lion's share of the health plans decided to do. I mean, yeah, but I will say, the conference, the Rise conference that I went to attended in December. I loved the panel discussion around this, because they really kind of changed my perspective at that time on, yes, uphold it. Say you agree, or yeah, whatever
Totally.
their perspective. I appreciate that, because it really changed my way of thinking when I went in there.
It is interesting. I thought there's a couple caps measures too, that CMS proposed for removal too. I wonder if it'll just be an all or nothing, or if we're going to see some of those come out and not others. I
Yeah.
mean, so here's my crystal ball. We'll see, right? Um, I'm thinking for sure those operational measures are going to come out. They're gameable, they're the easy button. CMS has made a number of changes with the intent to result in cost savings, and that they will not realize those cost savings because a lot of those changes did not come into fruition for various
Mm,
reasons. And they
hmm.
have they need to make up for that. And I think removing those operational measures from the measure schema is one step towards that, right?
Mm,
If that
hmm.
doesn't do it, the lever Phil just mentioned with the hold harmless, right? That's lever number two. So we'll see there. So my crystal ball says those operational measures come out. For caps, I'm going back and forth. I don't know, what all went behind some of the decisions
This,
around removing the customer service and rating of healthcare quality. Rating of healthcare quality, that's such a weird question. I don't think members know how, like, what do you mean healthcare quality and rating of the health plan, and what is. I'm fine seeing that go. I think it's confusing, right? Especially for
yeah.
some of the newer American populations where that verbiage just doesn't even tick and tie with vocabulary that folks use. But customer service kind of caught me by surprise, right? Like I saw that always as an important metric, and even
Mm-hmm.
in CMS's logic around in that proposed rule around why they were removing other measures, they stated part of the reason they were removing some of those measures, like call center, proposing to, right, call center, some of those others, is because it is measured through CAHPS, and it is measured through, they call that customer service. And then a couple of paragraphs go down to propose the removal of customer service, or I'm just like, those, I'm not connecting those dots. So I thought it'll be interesting to see
It will
what
definitely
actually
be interesting.
sticks.
Yeah, and that's a good question that you bring up. Is it going to be all or nothing, or will they kind of cherry pick? I mean, because that was a comprehensive list. I was like, what? I remember when I
Yes.
first saw it. I do like the fact that they're adding in some behavioral health aspects into it, and so, but yeah, I agree with the HE. I do believe that's a done deal.
And then
Yeah.
you have them asking, what other measures would you want to see removed? So what, Jessica and Jay, if you guys had to pick a measure that's not on the list that health plans are emailing CMS about, I'll tell you one that I think people are. But if you think about that list and a measure that people are emailing CMS about to remove, what do you guys feel?
That's a
OMW.
good
That's
question.
the first thing.
That's what I was
Oh,
gonna say too.
yes. Let's virtual
But
high five that. OMW. Definitely.
OMW. I'm like,
This
yeah, I
dumbest
have to
measure.
imagine OMW is on that list of people just not wanting to report that measure anymore.
I
it
think
is
so
such a
too, for
tough
so many
measure.
reasons. Like it's been in the stars, part of the star schema for years, and we really haven't moved very much on it, right? We're not seeing quality improvement movement. It's resulting in some gamification where I see some plans even saying, okay, every member this age and older, every female is going to get a bone density scan regardless of whether or not they fall and fracture,
Hmm.
because then when they do, they're going to enter the denominator and the numerator at the same time. That's gaming. That's abuse of,
Hmm.
that's just a waste of healthcare taxpayer dollars, and it's unnecessary treatment for folks. And I hear so many providers, I mean, just throwing my clinician hat back on, that so many providers saying, I know my female patient is X years old. I know she likely has osteoporosis. I'm not going
Hmm.
to
Yep.
make her take Fosamax. And for those of you
Yeah.
that didn't start in geriatrics, these are harsh medications. They
Yeah.
erode the esophagus. I remember having to go around in the nursing home, and I'm going to get my crank arm because we didn't have buttons back when I started 30 years ago. And we'd have to crank up everyone's bed, head of bed, all the Fosamax patients, for 30 minutes, just so that when we gave them that pill, it didn't come back up and burn their esophagus, right? So,
Ooh.
I mean, I won't, I'll stop down nursing home lane there, nursing home memory lane. But I think for so many reasons, right? Gaming, we can't move it, doesn't align with what many physicians consider best practice. Get it out of there.
And
You,
I
you
I
know,
look
I,
at
oh,
the Oh, sorry, Jay, go ahead.
no, 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 no. Go ahead. Please go. Because I
I,
was
I
going
was
to
just gonna say
compare something else.
what I always kind of laugh at is the cut points. Like, is that not an indicator of
Oh,
how many health plans actually care about this measure?
This
When your
measure.
four-star cut
Yes.
point is around the 50s, you don't have
yeah.
that many health plans really caring that much about it.
True. This is a good point.
Agree with you all on OMW. I'm going back in time, but I remember I felt the same similar way about the DMARD measure. I mean, or rheumatoid
Yeah.
arthritis. I felt like, the medication was harsh. Members didn't like to take it, or providers didn't like to prescribe it for whatever reason.
Yeah.
And it was like, and then it was sometimes, at least in Texas, that was one of the barriers that I saw, was that a lot of the two things: either the providers were giving the members samples. Of course, we don't get credit for that, no claim. Or the members were, just going over the border to Mexico to get it, a lot cheaper. So,
Oh, sure.
a lot of those little instances was like, it was like, this measure is proving to be difficult. So when it went away, I was like, yay.
Oh my goodness. Well, what other? There's so many changes. My brain is just spinning. I mean, what else can we talk about? There's how about med adherence? All the there we talked
Mm,
about some of these proposed changes that might come, but there are changes that are coming, right? And that are that are dependent on actions we're taking this year, right? We're being measured this year
Hmm.
for future star years. So we have the risk adjustment of those medication adherence measures. We have change in the methodology to those measures, right? With those SNP days and other days being removed
Yeah.
from the calculation of that measure. There's more, but and there's the mathematical implications of those things happening that we can talk about too, right? What does that mean for the weight of those measures for the year that they come in with a change? What does it mean for QI? Right? So let's go
Yep.
there. What are thoughts on some of those changes?
Well, and I think it's, going back to Jay's question, in 29, if all these operations measures get removed, that is the same year that those medication adherence measures go back to 3.
Mm.
And like you've got those 3 measures now going back to triple weight, you lose all those operations measures, they're suddenly worth a lot more. I mean, nerdy math,
Yeah.
a triple weighted measure, if you move it a star, it actually accounts for like 3.89 points towards your actual overall score. It's not just, you're not just moving it 3 points. So that's
Hmm.
going to drastically go up based on the number of measures that you report. And so yes, while the weight will still be 3, the amount that it actually contributes to your overall score will be a lot higher, especially with those operations measures out now. But um yeah, I mean, I think 29 is going to be a kind of a reset. I think it'll
Interesting.
be a
Yeah.
reset.
Yeah.
It'll be a landscape reset.
And watching, you did you put out a really great piece recently, Phil, about decreased impact of the categorical adjustment
Hmm.
index, right? And kind of those heavy dual enlist members that were counting on that bump to get there maybe ought to redo the math and not just plug in last year's adjustment and see where they might land
Yeah.
with some of the decreased impact. I wonder, and I'm sure you're starting to math that out now, but I wonder what the additional impact of removing these 3 triple weighted medication adherence measures from that CAI, calculation is going to have even more so.
Yeah. Yeah, it will. And these are all little nuances that if you're only paying attention to stars from a high level, right? Like I need to get to
Mm-hmm.
4 star with this measure. You miss those, you miss that CAI the changes in CAI are basically like you not hitting your star target for a triple weighted measure. You've got to push it a little bit more if you were impacted by that biggest change. And you have to look at it in such minute detail. All these changes, everything that impacts, and they all happen at different times of the year, which is even harder.
Right.
Yes. Yes.
Yeah.
I mean, we were kind of talking about each foot in each star year, right? 27 and 28. Kind of to circle back to that, that's what we're seeing right now, right? Like, especially with those HEDIS measures, those claims run out measures, you're
Hmm.
doing 2028 strategies right now, but you're also still moving the end result of those 27 scores. So even if you look at something like QI, right, when you're looking at significant improvement thresholds, if you're still pushing your hybrid measures up and up, and you've already built your 28 strategy around hitting an 85, but you end up hitting an 85 at stars 27 end of hybrid season, you got to recircle back and readjust your 28 pieces. So yeah, even those changes wrapping up 27 is impacting your 28 too.
Phil is my favorite nerdy math friend. Everyone needs a Phil.
If I can just say something, because I like what you just mentioned, Phil, because we are, I mean, leaders who manage multiple timelines are really the leaders
Yeah.
who stay ahead of the curve. And I think, of course, we're always thinking about in the current measurement year, how do we get these gaps closed and how do we perform to our highest ability? But then we should also be architecting, what next year is going to look like. But then
Yes.
somewhere in the middle of that, we're also at points of time going to think about historical performance and historical data. And I think that's just totally important. I think that if we are having like monthly check-ins or monthly strategy sessions, I think that those three should remain on like the agenda, if you will, because um, we do want to make sure that we're reflecting on the year prior. We don't want to replicate what's not working, and we want to understand like what is worth the squeeze, and what we can replicate and what we should avoid. And so
Yeah.
Yeah.
I do think that that we will see that leaders who manage multiple timelines are really, really effective in their approach.
I agree. Let me pivot a minute, if you don't mind, because Jay,
Yeah,
I've got a
yes,
really great question for you. So, as I
yes.
was like stalking your LinkedIn profile to learn more about our guest today, I noticed you have a lot of experience, and it's even been in some of the titles you've held around equity and ensuring equitable care
Mhm.
to members and populations within health plans, which I just loved. And I think a skill set like that is just so relevant to health plans today. And I say this because a lot of the health plans that Phil and I are working with are experiencing like these big influx of ethnic groups into their health plan that they did not pursue. They weren't out looking for. It wasn't an active and an intentional enrollment move, but rather
Mhm.
other health plans moving out of counties, changing benefits, contracting have caused these groups of members to spill into health plans. And these health plans maybe have had some sort of a health equity strategy, but it was centered around the populations they knew how to treat for years. And now they've got this whole new demographic coming in.
Yeah.
I would just love to hear your take on that. What are some resources? Where do plans go to quickly get up to speed and educate themselves on populations they really don't know too much about?
I absolutely love that question. I am very passionate about health equity. Along my career, in Medicare stars or quality improvement, health equity was never a part of my job description.
Mm-hmm.
And and the interesting thing is I find that it should be. I do find that we should ingrain all of those thought processes. But to answer your question, number one, we as a health plan, we have to start collecting the appropriate data. That's number one. That REL, which is race, ethnicity, and language, social drivers, geographical education status that helps us to understand around health literacy, um, financial income status, like all of those things really helps us to get a better picture of, again, who we're serving. And I do agree that performance data is not the only data that we should be using. I think we should be layering in this data. So we first have to collect it, number one, and then we should layer that data with performance to help give us a better picture again of like, the why and all of those things. That's number one. And of course, I'm really big on, tailoring. Again, we cannot solve for everything, but finding those common themes and those trends and making sure that we are solving for those specific realities that our members are facing. I mean, you know, honestly, if you have to, work with providers who are policy advocates or getting into the
Yes.
communities. I mean, like community health workers and people who are, we call, I guess, boots on the ground. They have so much more intel than we could ever have a lot of times in our organization in the corporate healthcare. And so partnering with these individuals, community advocates, even facilitating focus groups within the community, letting us hear what the members' needs are. And I will share another personal story. In one of my roles, I had the esteemed privilege. I don't even know how I got this privilege at that time, but I was tagged to join an executive leadership team to do a tour of Texas. Okay, and just so you know, Texas is a beast. At that time, we had 200.
Good.
We had 200. Yeah, it's big. At that time, we had 240 counties, and we had members in all counties. So I had the opportunity to join our health plan CEO, marketing, VP of marketing, you kind of you name it, and I represented the quality team. we did a tour of Texas meeting with members. And it was an opportunity for us to obviously provide a hotel conference room, lunch, and invite our members. We want to hear from you. And we presented to them. And a lot of the conversations were derailed because our members came with their list of complaints,
Yeah.
their list of barriers. And it was ever changing for me because now I am beyond the chasing of the stars. I'm beyond the numbers. I'm beyond. I now can take these stories, these barriers, all of this. A lot of it was like non-germane to my area, but I can still apply it to, why this is preventing this member from getting the access to care that they need. And so that experience, I must have gone, I didn't do the whole tour with them. I may have had the opportunity to do like 5 stops, but it was life-changing for me. And I think that is the inception of this whole health equity kick. For me is really just making sure that we understand who we are serving, respond to their realities, making sure that we get beyond just like the inner workings of health plan woes.
Right.
Yeah. Mm-hmm. Yeah, I'll share a story too. My wife's family is obviously in LA, and my mother-in-law is Hispanic, and she recently needed procedures done, and
Mm,
while her insurance was gonna cover them, she still much rather wanted to drive to Tijuana across the border and get everything done there.
yep.
So we, from a health plan perspective, we might do everything we can to understand the culture, understand the barriers, but it's so hard to just understand, you know, why somebody would drive 4 hours for a procedure that they could get done,
Mm-hmm.
locally. Lo and behold, it's still provider, it's provider network adequacy. That's the reason
Yeah.
why. I mean, she was going to have to wait 4 weeks versus a week. And, sometimes the provider network, adequacy piece is something that the health plan can't necessarily control.
I love that. So you heard it here from Jay and Phil, everyone. If you've experienced an influx of new members that you don't understand, stop trying to solve those problems around your boardroom table, right? Get out into the community and learn who you're serving and learn what their barriers are. Get some
Get some
denominator
street cred.
intelligence. Thank you so much, Jay, for joining us today. I think that Phil and I could just talk with you all day, but I see our producer popping up in the corner of the screen, which tells us we've run out of time. Really hope we get an opportunity to come back and interview you again sometime this year, because I
Yeah.
Thank you
think
so
there's
much. This was
so
a
much more we could
pleasure.
talk about.
Thank you so much. It was an honor and a pleasure. So I appreciate it. And I love the conversation. This is right. I mean, it helps me keep my chops going too. So this is great.
That's right. That's right.
It's awesome.
Okay. Thanks, everyone. Take care. Talk to you next month.
Bye-bye.